Muy buenas tardes, estimados participantes. Es un honor darles la bienvenida a este webinario, parte del módulo Avances en Prevención, Diagnóstico y Tratamiento de las Enfermedades Cardiometabólicas. En esta sesión abordaremos un tema fundamental en la medicina moderna: genética y enfermedades cardiometabólicas, avances en investigación y diagnóstico, a cargo del doctor Paolo Parini, un referente mundial en la investigación de las enfermedades cardiometabólicas.
Good afternoon, dear audience. It is an honor to welcome you to this webinar, part of the Advance in the Prevention, Diagnosis, and Treatment of Cardiometabolic Disease module. In this session, we will address a fundamental topic in modern medicine: genetics and cardiometabolic disease, advancing research and diagnosis, by Dr. Paolo Parini, a world leader in cardiometabolic disease research.
El doctor Parini posee una destacada trayectoria académica y profesional. Él es doctor en medicina por la Universidad de Bolonia, doctor en filosofía por el Instituto Karolinska en Estocolmo, Suecia, especialista en gastroenterología y endoscopía digestiva, director de investigación y desarrollo del Instituto Karolinska, profesor médico titular en el Departamento de Medicina Udinge y en el Departamento de Medicina de Laboratorio, ambos del Instituto Karolinska, profesor de Química en el Instituto Karolinska, coordinador de la Unidad Cardiometabólica, consultor senior en el área de pacientes de endocrinología y nefrología en el Hospital Universitario Karolinska, profesor invitado en el Departamento de Ciencias Farmacológicas y Biomoleculares de la Universidad de Milán.
Dr. Parini has an outstanding academic and professional career. Doctor of Medicine from the University of Bologna, Doctor of Philosophy from the Karolinska Institute, specialist in gastroenterology and digestive endoscopy, Director of Research and Development at the Karolinska Institute, Professor and Senior Physician at the Department of Medicine, Zurich, and the Department of Laboratory Medicine, Bath, at the Karolinska Institute, Professor of Clinical Chemistry and the Karolinska Institute, coordinator of the Cardiometabolic Unit, senior consultant in the patient area of endocrinology and nephrology at the Karolinska University Hospital, and visiting professor at the Department of Pharmacological and Biomolecular Science at University of Milan.
Además, ha desarrollado una destacada actividad postdoctoral, incluyendo su labor como investigador visitante en el laboratorio profesor Larry L. Rudel en la Facultad de Medicina de la Universidad de Wake Forest en Estados Unidos, investigador de la Unidad de Metabolismo del Departamento de Medicina del Instituto Karolinska.
He has also developed notable postdoctoral work, including his work as visiting researcher in the laboratory of Professor Larry L. Rudel at the Wake Forest University School of Medicine in the United States, and researcher at the Metabolism Unit of the Department of Medicine at Karolinska Institute.
El doctor Parini es un prolífico investigador con numerosas publicaciones científicas en el campo de la genética y las enfermedades cardiometabólicas, entre las que destacan varias publicaciones que han sido publicadas en revistas indexadas. Doctor Parini, es un verdadero honor tenerlo con nosotros esta tarde.
Dr. Parini is a prolific researcher with numerous scientific publications in the field of genetics and cardiometabolic disease. It is a true honor to have you with us this afternoon.
A nuestros participantes les recordamos que pueden dejar sus preguntas y comentarios en el chat, los cuales abordaremos al finalizar de la conferencia con el doctor Parini. Le cedo la palabra para su presentación, doctor Parini.
Go ahead, Dr. Parini.
Okay, thank you very much, and thank you also for the nice introductions. unfortunately, I cannot speak Spanish, and I apologize. I will speak in English, and please stop me if what I'm saying is not clear. And if understood right, we will take the questions in the end of my presentation. So I'm going to share my presentations, and let me know if you see it. Do you see it?
Yes.
Yes. So again, it is an honor to be here, and Dr. Sandoval asked me if I could give a presentation, and definitely I say yes. I still remember when I was, I think it was more than 1.5 years ago in El Salvador. It was a very nice meeting, and I'm very glad that the collaborations is still going on among us. And again, you're also very welcome to come and visit me at the Karolinska and in Stockholm. So the topic of my questions, or my talk, sorry, is genetic and cardiometabolic disease. I tried to give a little bit a very simplified overview of more or less, rather than the field or the problems or the possibilities. These are my disclosures, and I have no specific disclosure for these presentations. And I mean, if we start and we discuss what metabolic disease are, metabolic diseases are actually a big problem of globally, not only a problem of El Salvador or a problem of Sweden, where I live. They almost are believed that will affect 1/3 of the world population in less than a decade. And you can see here is both diabetes, kidney disease, stroke, heart disease, liver disease. And regarding the heart disease, the majority of the cardiometabolic disease related heart problems are deriving from the atherosclerotic cardiovascular disease. If we look at, and I apologize because I couldn't find more recent data, but if you look at the cardiometabolic burden in Central America and looking also El Salvador, you can see that the sum of the cardiovascular disease, chronic kidney disease, and diabetes mellitus make a big part of the let's say, so mortality in the countries, and also very much important to see that the mortality because of cardiovascular disease account for almost 60% of the premature mortality rate, and there is very high, let's say, so prevalence of metabolic syndrome in El Salvador. One of apart diabetes that has a prevalence of about 12%, 10% in men, at least the data I could find in the literature. But if you look at the global observatory for El Salvador, and we look one of the really per se consequences of the cardiometabolic disease and also driver of the cardiometabolic disease. So a causal factor in a way, that is overweight and obesity. In El Salvador, we see that there is women are tendency more obese and overweight than men, and there is no major difference between boys and girls. If we look at the percentage number of overweight person and obese person compared to Sweden, they're not much different. It's not that people is more or less obese, but what is different is the opposite between men and women. So you can swap women instead of men and men instead of women, then more or less you will have the same picture in Sweden. These already tell us also it's something that I will come back, that it is very important to understand the heterogeneity of the cardiometabolic disease that is coupled also to local environmental factor and also local genetic factors. What I always say that in cardiometabolic disease, there is more or less a peripheral clinical phenotype that is a combined dyslipidemia. There is elevated level of triglyceride and sometimes also level of increase in LDL cholesterol, more often maybe decrease in HDL cholesterol. But the classical almost picture that I see every day when I go in, or every Monday and Tuesday when I go to the clinic, it is really a combined situation where there is a mild hypertriglyceridemia with a mild hypercholesterolemia. And if in the stream of the hypercholesterolemia and the stream of hypertriglyceridemia, you have more the monogenic form, rare diseases, sometimes like homozygous FH, that is homozygote familial hypercholesterolemia, or the familial hyperchylomicronemia, that is or familial chylomicron syndrome, that is a life-threatening condition that can cause pancreatitis because of impaired handling of lipid in the postprandial phase. But the majority of the patients, as you can see, have a combined dyslipidemia, and the problem is polygenic. And independently or dependently by genetic factor or by environmental factor, the same disease more or less happen more in the heart or in the liver or in the kidney, or you can give you neurological problem like strokes or like diabetes mellitus. So sometimes we are discussing whether it's the same patients or the same pathophysiological process creates the difference, let's say, so it creates different diseases. What are the factors that make the same pathophysiological process in some person manifest more in the kidney rather than heart, other in the liver? But let's say so we have also to be aware of that cardiometabolic disease or a cardiometabolic condition. I mean, a patient who has diabetes very often has problem with the heart, very often a problem with the kidney, and very often a problem in the liver. So let's say so we talk more now of a multimorbidity conditions, not only a disease that have different impairment in different organs of the body in the same person. And then also, I will come back later in the end of this presentation, it is sometimes create problems how to handle these patients, because medicine today is organized in medical domains that are very much based on specialty, that are very much based on the organ. And then the, let's say, management of these patients is very much in silos. So if you are a cardiological patient, often, or you are a pathological patient or a kidney patient, the specialists that you meet, they follow specialty focus guideline and miss the, let's say, so multimorbidity approach, because they always try to treat their specialty golden standard as a biomarker. Like, for instance, if you come to a cardiologist, definitely one of the golden standard will be LDL cholesterol. And if you go to an hepatology, other parameters like liver enzymes or the presence of liver steatosis or no. So, as you can see here, as again, the polygenic, the genetic and heritability is very, very important in the cardiometabolic disease. And you can see here that the coronary heart disease heritability, for an example, is around 40 to 60% overall. Is very, very important in the early onset of the disease, in the early premature cardiovascular disease. The heritability of diabetes is very high, as an estimate around 74%. And also what is interesting that there is no more or less gender-related differences regarding diabetes type 2 mellitus. And then, of course, it's very, very important the environment. We come back to that one. And of course, the concordance rates are very high in the first degrees relatives, twin pairs, and the parent offering relationships. And we have, let's say, so variants that are directly contributing to the pathophysiology, but variants that may correlate with the disease status. That's why it is very important that every time that we find an association or a specific genetic variance with a disease, one of the first questions is to understand what are the functional consequences of that variance, to understand whether is in the pathophysiological path or is outside. And this is very important because now we know that we have created or organized several intervention trials trying to increase or decrease a biomarker that was determined, for instance, from some genetic variability, because we thought that it was within the pathophysiologic path, but this intervention failed, telling us that this was more associated to the risk, not, let's say, so causing the disease. If you look at the data available for the let's say, so, genetic study, the majority of data in the literature are related to GWAS, genomic-wide association screening, where you have, let's say, so you look at a single nucleotide polymorphism that could be within or in the area around the gene, and the association to the disease. In the case of cardiometabolic disease, association with cardiovascular disease, diabetes, and, for instance, lipid trait. You should be aware of that all GWAS. So when you look at all the studies, or when you look at meta-analysis study, some of the first GWAS studies were not of such a high quality in terms of the technology used. There were some chips, it's very much chip-based assays, were not so maybe, let's say, specific and sensitive and accurate. But anyway, now there are possibility to screen more than 2 million of genetic variants at once. So it's technologies improved tremendously. This has created the possibility also to studies large population studies, large sample size, to find a significant association between the, let's say so, the genetic variants and the disease. The current estimate that for cardiovascular disease, more than 250 loci has been identified. Again, for cardiovascular disease, around 400 SNPs has been identified, loci has been identified for diabetes type 2, more than 500 for the lipid traits, as you said, the LDL cholesterol, the triglyceride, and the HDL cholesterol, and 450 loci has been identified for the obesity. One of the problems, let's say, so GWAS study, the number one does not explain the heritability, and also there is a lot of population bias because the majority of GWAS data generated for European ancestry individuals, so there is. But there is also other, let's say, so, other aspect you have to consider, that it is very, very important to understand if let's say so, these genetic variants are functionally active. They impair the functionality of a gene. They impair the, let's say so, expression of a gene. It is very much also important to understand in which kind of cells are active to really understand better the why this. If you want to look at the latest number of, say, variants or loci associated, you can go to the NHGR EBIG-WAS catalog. Also look at this cardiogram plus C4D, that is a very recent meta-analysis. But you have also, I will tell that in the end, keep in mind now you need very high number of people to be studied. And this is because the traits we are looking at are really polygenic, but also because maybe the different polygenic has indeed a role in the population, the genetic variants, but in the single individual, the contribution to the peripheral phenotype maybe is much less important compared to lifestyle factors. I will come back to that. In the GWAS analysis, and the result for the GWAS analysis has been also used in a very interesting way how to look and study these genetic informations, that is Mendelian randomization studies, where you choose different single nucleotide polymorphism, and you have your population study, the one that have one allele, the one that have both, they are homogeneous for one allele, one single nucleotide polymorphism, population that have heterozygotes, or a population that are homozygous for the wild allele, or one single gene or different genes, and then they are let's say randomized for all the other genetic variants. And this kind of Mendelian randomization study has been very useful to, at large, maybe exclude rather than prove, exclude the possible contributors to, let's say, for instance, atherosclerosis. Today, we know that maybe the role of HDL cholesterol in protecting in doing a protection for cardiovascular disease is much less than we thought, and definitely the association maybe is just a risk marker, and the role of HDL in the cardiovascular disease is more related to modulation of innate immunity and acquired immunity rather than being a lipid particles that extract cholesterol from the arteries, that how maybe it was thought in the beginning. So it's also very nice that by GWAS studies and Mendelian randomization studies, they contributed to a better understanding of the physiological process. Of course, now, at least also here, I think it's the same in El Salvador, I think that if anything, especially in the clinic, we rather like to have whole exome sequencing or whole genome sequencing. We use it regularly in the Karolinska University Hospital for selected cases in order to understand which kind of problem patients has, and the reason why we use it in selected cases, because unfortunately this technology is still very expensive, so it's very difficult to have an extensive use in clinical routine assays. But anyway, there have been huge studies that has been done. One is usually UK Biobank, the whole exome sequencing, where more than 200,000 participants been there, and from those studies, 57 gene-based association has been identified, association with the cardiometabolic traits, for instance, the lipid in blood and diabetes. There was a example of genes. I'm going to give some example of genes because the association there with so many genes that, I mean, it will take a few days to list each one of those. But for instance, MIBPC3 with cardiomyopathy, and then LDL receptor with hypercholesterolemia, GC1 with MODY, a patient PKD1 with renal disease, and PTN with heart failure. So these are the top med consortium that report more than, let's say, 100 lawsuits for blood lipid trait via wide genome sequencing, as we include the novel variants, also for instance in apolipoprotein B gene, the ApoB gene, and PCSK9 genes. And for who is working in the pathogenesis of these lipidemias and atherosclerotic cardiovascular disease, looking and seeing ApoB genes and PCSK9 genes, say, well, this was expected, but still it was new, that kind of information. The interesting thing is also that the whole genome sequencing and the whole exome sequencing can give and inform in rare variants that maybe are left not so much fetched by the GWAS study. So variants in GIGIF1, HNF1, 1A, sorry, SECI and J11 has been associated with population-specific risk for diabetes type 2, and rare coding variants in angiopoietin 3 with triglyceride and ApoC3 with HDL. And this is quite interesting because actually there are genetic therapy based on antisense oligonucleotides or small interference RNA aiming at targeting these genes, and by switching off also this gene has been found, especially for triglycerides, a way how to decrease. So these also genetic studies has identified unexpected therapeutic target. So the World Exome and Genome Sequencing Study is giving a specific insight of, for instance, the Hispanic Latin American population. The best identified SLC116A11 for type 2 diabetes risk and ABC1 for HDL regulation. When looking at European versus non-European population, there was a 30% of the lots that show ancestry-specific effects. And this is very, very important. Again, if you look, as I said before, a lot of studies done in European. So that's why it's very important to understand the different world area where this information should be implemented in treatment or in diagnostic procedures. And again, we said that about the PCSK9 or the documented consorts. But here is to give you a list or an example of the outcome of those studies. And you see that there are both genes linked to cardiomyopathy, hypercholesterolemia, MODY, polycystic kidney disease, heart failure, diabetes type 2, obesity. There are, again, a high number of genes. But again, these, let's say, studies very much focus on the association with the, let's say, other ratio for the disease. They really didn't look at the progressions of the disease or progression of clinical phenotypes into the disease. I just show you these, let's say, so a paper that came out very recently. I think it was February the 3rd, 2025, is in the bioRxiv X, is from Stanford University, where they use the data from UK Biobank to create what they call the polygenic Hadar scores, using a new, let's say, statistical approach that is able, let's say, so to fetch the progression of the disease. So now is interesting because if G1s and the classical wide genome studies or all the rest are, let's say, so in a way, static studies, now has been developed. Also, with an algorithm that is used, it's called Basel, is used by these researchers how to study progression, and they apply these SNP, SNP-net Cox regressions. The thing is this one that they use a study cohort and they combine also with operational phenotypes. So there is a combination of genetic information with operational information. and they, let's say, so are able to study that the progression, and they have identified several let's say polygenic hazard score, and here are some example. So there is a key variance in the near the LMO1 gene that has a protective effect for what? For protection for going from hyperlipidemia to need of CABG surgery, or there is a gene, the OMOD gene, that has a, let's say, polygenic hazard score that predict in a way the progression of diabetes and kidney failure. We have here this genetic variant is associated from hypertension going into stroke and obesity to heart failure. FTO gene is one of maybe oldest gene for which we knew the genetic variants were associated to adiposity. But it's interesting now also to see that in those people who have adiposity and have a genetic variance, that the gene may have a tendency to develop heart failure and metabolic syndrome with developing into diabetes. So what I want to say is that there is a lot of, so a way out to relook at the data, the information that are available, and merging with different kind of information of different nature can also give information on the progression of the disease. The clinical implications are very large. Of course, these kind of polygenic hazard score are very important to create a precision monitoring, so not only precise diagnostic of the disease, but a precise prediction of how the disease will progress. And again, also this kind of study have a lot of information about the heterogeneity of the different population. Once more, unfortunately, these studies are mainly based on European ancestors, and there are still very much mechanistic gaps. So this, for instance, because I was looking in the literature, what genetic factor may influence cardiometabolic disease in the Salvador populations. I didn't find many, let's say, studies of large sizes based only on the, let's say, El Salvador population. So it's more on the Central Americans, including El Salvador, or with indigenous Americans. I myself learned when I was in Salvador. I mean, there are different, let's say, a community of people or different ancestor. Is not at Central America or Latin America or let's say are only one kind of had only one ancestors. So it's very much important, but is very interesting to see that there are clear gene associated to the type 2 diabetes risk, also the SLC 16A11, or to the HbA1c gene with low LDL cholesterol. And you know that if you don't have, genetic variant that totally abolished the functionality of ABCA1 gene inherited in a homozygote form, or if you are in a compound heterozygote for a deficiency in ABCA1, you have a disease where you don't have HDL cholesterol, the disease called TAGIA. And also you have, of course, genetic heterogeneity for disease susceptibility that are, for instance, determined by genetic variants. So there is very much important to understand the diversity of the genetic studies. There are, this is overview or simplified of different kind of, say, ancestor. You have in a different part, I think is very productive in that sense. The list should be much more long. You have, of course, environmental interactions. And the environmental interaction may be per se a driver of the disease. They don't need to be associated with any particular genetic variants, but definitely the same, let's say, so I used to say, for instance, if I have patients with familial hypercholesterolemia, you cannot cure the disease with the diet, but if you have the wrong diet, you can do only worse. But if you maybe have a polygenic form of hypercholesterolemia, you may cure it sometimes only with diet. So it's very much interesting. And of course, there is integration of multi-omic data. And I want to switch a little bit and tell you maybe an appetizer if you would like to invite me once more and listen to me, is what we are doing now in my lab. This is, I call it the Paolo's headache at the clinic, because both for the doctors and the nurses, sometimes it's impossible to implement the guideline when you meet a patient, the single patients. The guideline never talk about a patient that exists. A guideline talk about averaged patients. So but then you have in front the person. And this is, for instance, the result of a study, very nice study, of, let's say, Mendelian randomization study, or study, genetic study, actually, this was, for remnant cholesterol and other ratio for aortic valve stenosis. And this study had huge number of patients. And these patients, according how you round the result, you can either cluster to the fourth quintile or the fifth quintile. And if the fifth quintile is not really at risk, but the fourth quintile is at risk, and then you have to make a decision. And one of the problems is this one, that number one, why I need to see so many, let's say, observation, and maybe because the cholesterol, the remnant cholesterol in regard to atherosclerotic valve stenosis is a driver of disease, but not contributing to the majority of the pathogenic process. But the problem is that you have to understand the single patients in front of you. One of the problems is that we have in the past, and we still do use a lot of reductionism in medicine. And the reductionism in healthcare because the patient with common symptoms and signs share the same disease mechanism. That's not true. Or maybe the same disease pathophenotype should always give the same symptoms, and it's not true either. And also respond in the same way to medical procedural and behavioral interventions. And also is not really the case. Reductionist medicine that by, let's say, studying complex disease in creating simple model was very successful in the past. Let's say, maybe not so successful now in understanding complex disease like the cardiometabolic disease. So in the last 5 years, we started to use very much a new field of medicine that is called network medicine. You have a system biology, you have system medicine, and an evolution system medicine is network medicine. And there is network science, physics, apply mathematics and statistics, computer science, biology, applied to medicines. And where you see the single patients as a unique entity, patients with the same clinical picture do not share necessarily the same disease pathophenotype, or the opposite, the same disease phenotype may not result in the same clinical picture. And rather than, because when you look at polygenic score, you sum the variance of the phenomena you are studying explained by the single polygenic, by the single genetic variance. We are much more interested in understanding the interaction between the different the factors. So if you are in the future interested to learn more about network medicine, we'll be glad to come back and talk a little bit about that. I thank you for your attention. If you come and visit me in Stockholm, all of you are invited. We can, if you come this summer, go out sailing with my sailing boat. Thank you very much for your attention.
Thank you, Dr. Parini. We have a little question for you.
Yes.
What would be the ideal lifestyle since childhood within the family to keep healthy and avoid this metabolic disease? For what is the paper of the progenitors of the parents in childhood?
This is a very relevant question because it touches upon something that is called preventions. And in the early preventions, so definitely you have to do, let's say, in early preventions that start already in children. And in terms also lifestyles, independently of the genetic background of the patients. If the parents or the grandparents had, for instance, type 2 diabetes, is even more important. If they had cardiovascular disease, is even more important. But in terms of, for instance, the increased physical activity and in terms of dietary hygiene, in meaning eating right, as soon as possible. In the sense, we know, for instance, when I was talking with, for many years ago, I was coordinating European projects, and there was colleagues working on stem cells or early precursor of adipocytes, and you determine the number of adipose cells very much between age 5 to 10. Then after 10, you don't increase very much maybe the number of cells. You may increase their size. Okay, so definitely children that are little overweight early in their childhood will have much more trouble in later adulthood to keep a good body weight. That's why it's good to increase. In this program, very important to be done in school. I don't know now the school in El Salvador, but for instance, Sweden, at least until you go, this not occur when you go to the university, but until you go to the university, you eat lunch at school. And the quality of the lunch at school is very important, although maybe the taste of the lunch at school is awful because it's to be done for so many students that if I hear my daughter every time she comes back from school, it's terrible. The other thing is the physical activity, and it's very, very, very important. Then, for instance, I'm very much a lipidologist, so we screen children in case of familial hypercholesterolemia. We start treatment of children at the age of 7, 8, also because the medical intervention is much less degrees. It's possible a disease of the different organs of the body in the population. Let's say, so, and this is a very interesting question, if it's possible prevention disease of the different organs. I would say, so you have to make always an approach in holistic approach. And definitely, for instance, some dietary intervention, they may, let's say, so help an organ but damage the other organ. We were discussing about, for instance, the different kinds of fatty acids. Saturated fatty acid and monounsaturated fatty acid, they drive liver steatosis very, very high. Maybe the monounsaturated fatty acid are less dangerous than the saturated for the heart, but definitely I would rather have the polyunsaturated fatty acid. And what I have, you can see from my name, originally from Italy, so we use a lot of extra virgin olive oil. And the good part of the extra virgin olive oil is not a fatty acid composition, it's the presence of polyphenols. And unfortunately, the olive oil that are high in polyphenol, the extra virgin olive oil, the high polyphenol, are the ones that are expensive. And now here becomes that actually the prevention of cardiometabolic disease became a social issues and the political issues. The classes of the society who has less money cannot do early prevention. And actually, and it's terrible because I am from a school that the child never choose the uterus from which she or he came from. So a child never choose the family where he was born. But this is a factor that will affect the health life of the citizens the rest of the life. That's why it is important that the state, I'm not talking about socialism or left or right, but if one of the meaning of the state is to cure and take care of its citizens, then the state has to invest a lot in prevention, early prevention in school, because it's very difficult to do early prevention at home, when often parents have many other things to think than what the food give to their children.
Respondiendo a la pregunta, en definitiva, es muy importante la prevención temprana, aún así sin que exista un trasfondo de antecedentes genéticos. Por ejemplo, se menciona como en problemas de hipercolesterolemia, podemos iniciar el tratamiento en niños a los 8 a los 9 años, pero también no es de olvidar que esto tiene un enfoque holístico y debe mucho enfocarse en una intervención dietética y es de tener cuidado con las grasas saturadas y también otro de los inconvenientes o factores que se deben de tener en cuenta son las clases sociales, ya que tiene mucho que ver cómo ese problema para poder iniciar una prevención temprana, aunque lo ideal sí es que exista una prevención temprana, ya que es muy importante y es importante también que el país cuide de ese estilo de vida desde la infancia. Okay, we have other question, Dr. Parini.
Yeah, and I apologize. Now I realize that you have to translate, so we'll
No,
not
no, no. It's no
answer
problem.
for 10 minutes.
We can do
So,
a summary.
yes, yes.
Are nystatin worth taking for life to prevent cardiovascular disease, or it's not necessary? What is your opinion about this?
I mean, we are talking about statins, the statins in general, I used to say to my patients when they ask me for how long I have to take, and I used to say until you are 92, 95 years old. And why that is because around after 90, our physiology changed, and we have survived all the deadly disease like the cardiometabolic disease, and we die because we worn out, we consume ourselves. Then in that context, maybe cholesterol and triglyceride may help to worn out slightly lower. So yes, until I do it when I have a patient that is 92, 95, I start to take out the statins. Also because, yeah, sorry.
Okay. En definitiva, sí se podrían utilizar. Yo tengo un paciente el cual lo utiliza. Tengo un paciente que tiene entre 90 y 95 años y sí me ha ido muy bien el utilizarlo. We have other. What do you think about the racial mixing? The population racial protect us from disease for cardiometabolic disease or no?
Ma let's say so, yeah. In general, when you mix different races, you mix also the different genetic variants, and usually the weakest genes are not taking over. So you don't have a genetic drift. So actually, more we mix ourselves, better it is.
Ok, en general, cuando mezclas los genes pueden llegar a ser débiles, pero no todo el control deriva de la parte genética. Así que en realidad, entre más nos mezclemos, podría ser mejor o sí podría haber una protección.
So for instance, Monday morning, I had a patient who had a very severe form of, no, sorry, that she had a very, yes, a patient, a female patient who had a form of familial hypercholesterolemia, heterozygous. She married her cousin from mother's side. The carrier of the disease was her mother. They got a child, 4 children, one with homozygote familial hypercholesterolemia, 2 with heterozygote, and 1 with no disease. So this is an extreme to show you that definitely you should not marry and have children with your relatives, maybe not even with the people you belong to. That's why my wife is from Germany and I'm from Italy.
Ok, dando un ejemplo, este lunes por la mañana tuve una paciente la cual tenía antecedente de hipercolesterolemia familiar y era genéticamente heterocigota y tuvo 4 hijos. Uno de ellos sí portaban los genes heterocigotos y otros eran homocigotos. Entonces, sin importar las mezclas, es algo como improbable. Tal vez ni siquiera puede ser que sí le trasciende o no. Eh, ¿Cuáles podrían ser, sorry, which modifiable habits have the greatest impact of mitigating or reducing risk of metabolic disease? You can tell me, or you can talk about modifiable habits.
Yes. Stop to smoke if you smoke. Have a very healthy diet and not too much calorie. We eat too much in comparison to what we burn. Independently, even if we eat very high quality food, we eat too much. So reduce the amount of calorie, increase the quality, stop smoking, don't drink alcohol, maybe 1 glass a week. And because it's a lot of calories, and also alcohol is not help your liver, and the other is physical activity. So if we stop to use our car and only walk, there will be a lot of improvement. But definitely you cannot walk if you're already very much overweight or have obesity, because then you will really kill your knees. So you have to do everything slowly, but definitely.
Ok. Primero, si fumas, dejar de fumar o el no fumar podrían ser otros hábitos modificables. La reducción también de las calorías en las comidas, el no beber alcohol o si se llega a beber tal vez una vez a la semana. El también estar a la par con la actividad física o, por ejemplo, si nosotros andamos en auto, muchas veces podemos también tener la opción de comenzar a caminar, aunque sea despacio. Claro, siempre teniendo en cuenta si se tiene algún antecedente, por ejemplo, de algún desgaste de rodillas o de meniscos. Entonces, todo sería poco a poco.
Yeah, then there's also a question of Christian Romero, who asked the most genes gained from parents or acquired through the de novo mutations. Let's say, I would say that the most genes are from the parents, but it always happen new mutations all the time. And in the past, it was believed that it was a woman was carrying all the new mutations. So all that the woman was more mutation. No, that's not true, because the egg of a woman are actually created during the embryonal development, and they are frozen in the first part of the second meiosis. Whereas is the male always accumulate new mutation in his, let's say so, testes. So if you want to transmit less new mutation to your children, then you have, as a male, try to get children as soon as possible. Not wait until you are 80 or 70, because then you will have a lot of new mutation in your spermatozoid. apart all the mutation you have inherited, but the majority is from inheritance.
Doctor Parini, muchas gracias por dedicarnos su tiempo en esta presentación, actualizándonos acerca de el panorama genético acerca de las enfermedades cardiometabólicas.
It was my pleasure, and hope to see you soon in person. Thank you very much. Very appreciate. It was an honor on my side. Thank you. Bye
Gracias,
bye.
doctor Parini. Gracias a todos.
Gracias.